സുരേഷ് സുരേഷ് സുരേഷ്
ഗൗരി ഇല്ല സാറേ, ഗൗരിക്ക് എന്തോ കണക്ഷൻ കേറിയിട്ടില്ല, വന്നിട്ടില്ല.
കേറിയിട്ടുണ്ടായിരുന്നല്ലോ കുട്ടി.
ഇല്ലില്ല, ഇപ്പൊ കാണുന്നില്ല. അതാ ഞാൻ വിളിച്ചോണ്ടിരിക്കുവായിരുന്നു സാർ.
അല്ല, നമ്മളൊരു ഫൈബർ കണക്ഷൻ ഉള്ളിടത്ത് തന്നെ ഇരിക്കാൻ പറയണം. ഒന്ന് ഒരു ട്രയലും ഒക്കെ എടുക്കണം. സാധാരണ മറ്റേ DIAP ചെയ്യുന്ന പോലെ ചെയ്യണം, അല്ലെങ്കിൽ പിന്നെ നമ്മളൊരു കണക്ഷൻ ഇല്ലെങ്കിൽ വലിയ പ്രശ്നമാണ്.
സാറേ ഒരു മിനിറ്റ്, ഞാൻ ഒന്ന് ഫൈൻഡ് ചെയ്തോട്ടെ. ജോസ് സാറേ, അവർക്ക് വീഡിയോ എന്തോ ഇഷ്യൂ ഉണ്ട്. ഒരു 2-3 മിനിറ്റ് അടുത്ത ഒരു കണക്ഷനിലോട്ടൊന്ന് മാറിക്കൊണ്ടിരിക്കുക. അവർക്ക് വീഡിയോ ലോഡ് ചെയ്യാൻ പറ്റുന്നില്ല, സൂം സ്റ്റക്ക് ആയിപ്പോയെന്ന് പറഞ്ഞു. ജോസ് സാറാമേ ഓഡിബിൾ?
ഞാൻ കേട്ടു. അവര് ഉടനെ ചെയ്യും അത്.
2-3 മിനിറ്റുള്ളിൽ ചെയ്യും സാറേ. ഒരു പൊസിഷൻ മാറി പുതിയ ഇതിലോട്ട് മാറി നെറ്റ്വർക്ക് മാറുക.
ഇനോഗ്രേഷൻ ഒക്കെ കഴിയട്ടെ സാറിന്.
സുരേഷ് 2 വാചകം പറഞ്ഞ്
ഇൻട്രഡക്ഷൻ തുടങ്ങാം സാർ. അവര് പിള്ളേർ ആ സ്റ്റുഡന്റ് ഒന്ന് കയറിയിട്ടാവാന്നുള്ളതാണ്. ഞാൻ 1 മിനിറ്റ് ഒന്ന് വെയിറ്റ് മാത്രമെങ്കിലും കയറി.
അല്ലെങ്കിൽ അവരൊരു ടെൻഷൻ ആയിരിക്കും.
അവർക്ക് ടെൻഷൻ ആവും.
എനിക്കെന്നാ ഓൺലൈൻ ഇൻസ്പെക്ടർ വന്നപ്പോ ഒരു പിന്നെ വൈഫൈ സ്ഥലം മാറ്റി. നല്ല വൈഫൈ.
We had a good connectivity in the lecture hall. അത് നമ്മള് ഇൻസ്പെക്ടർ വന്നപ്പോഴത്തേക്ക് നമ്മുടെ ഓൺലൈൻ ഇൻസ്പെക്ഷൻ വന്നപ്പോ അന്ന് എക്സാം ഹാളിലേക്ക് മാറ്റി കൊടുത്തായിരുന്നു. 2 മിനിറ്റ് സാറേ.
Sir. Yes, sir. IAP President of Kerala. Na guide, na thesis guide, diploma, pre-unit chief.
Sir, am I audible?
Gauri join ചെയ്തിട്ടുണ്ട് തുടങ്ങാവേ.
Good evening to all. Good evening to all. Good evening to all. So, respected Jose sir, Narli madam, Shanavas sir, Naveen sir, Sushma madam, Pushpathaman sir, and we are all senior faculty members and friends on this forum. So this time we are having Kottayam IAP and ICS Kottayam is conducting the PG club this time. So this time we have a very wonderful faculty for us. So we are having a neonatology case and come all the office bearers of IAP Kerala, especially Jose sir and the senior faculty members to this session. Again, I welcome Shanavas sir and Naveen sir for this session. So when I asked for this session, Naveen sir wholeheartedly accepted the invitation and was ready to do anything for conducting this session on 18th. So even without any hesitation, he accepted the date and we will conduct that session on 18th. So thank you, sir, for your kind acceptance of that, being the faculty for the day. So I welcome all of you to this platform. Hope you will have a wonderful teaching experience, learning experience out of this session. So over to Jose sir for your direct remarks.
Thank you, Dr. Suresh Vadakkedam. And at the outset, I express my sincere apologies for the delay in the starting the program. Actually, every week we sharply start at 7:30 due to the Wi-Fi issues. We delayed this program. Respected the senior faculty of today's program, Dr. Naveen sir, Professor Dr. Shanavas sir, Dr. Darli madam, Purushothaman sir, and today the mentor Dr. Surya Keke, and the presenter Dr. Gauri, and the faculties joined from Sri Shailam from outside Kerala for Hyderabad. He joined. He's a national AP member. and those who are joined from outside Kerala, welcome to our IAP Kerala activities, important activity of PG clinic clubs. Last Thursday, due to the untoward incidents of strike of IMA, we were not able to materialize PG club last Thursday. So today, the program is very important program for the today, as Dr. Suresh mentioned, the newborn case discussion regarding the jaundice by none other than our senior faculty, Dr. Naveen Jain sir. So I request all the faculties to join and all the PG students and all the IAP members join here. Please do and please mute all your audios, because last time we got a lot of disturbance during the PG discussion, because this is a serious matter we are discussing. So whenever you are at home, please mute your video and audio while you are starting the program. But last time we had a lot of disturbance. So this is a humble request as a president of IAP Kerala, mute all your audios for when we are starting the programs. I think this program is very, very useful for the PG students to their clinical experience, to gain experience from the senior faculty from the teaching institute like Dr. Naveen Jain sir regarding the neonatology issues. I think this program will be very useful for all of you. And with this words, I wish you all the best program. Jai Hind, Jai IAP. Over to Dr. Suresh for further proceedings.
Darling madam, for your words.
Dear all in the Zoom platform, I wish all the success for this program. I don't want to delay the program any further. Thank you.
Okay, madam. Thank you, madam. I think Naveen sir don't require any introduction to this. He is the most senior most of the neonatologists.
Nothing, sir. Already delayed, no problem, sir. Already delayed. You can continue, no problem.
Shanavas sir, please.
Nothing to add, sir. I'm the best for the program.
Okay, thank you, sir. Thank you, sir.
Okay.
Okay, thank you, sir. Naveen sir has done his MBBS and MD from Trivandrum Medical College. Then she went to PGI Chandigarh for taking the DM course, and after that he joined the KIMS Trivandrum, and there he started with the DNB program for neonatology and also the IAP fellowship program for neonatology. So he is the senior most and trainer or teacher for many of the neonatologists of our generation right now. So sir is a great faculty for neonatology. He has got lots of publications in his name, and he has authored the book for the highest newborn. He is a co-author and editor for the book and contributed to many chapters in the neonatology textbooks also. So I wish all the best to Gauri, and also a word of thanks to Dr. Surya who have trained her for this session. So I request Naveen sir to take over the program. Thank you.
Gauri, you may
Over to
present.
Naveen sir.
Gauri, you can present.
Sir, you can unmute.
Please start, Gauri.
Okay, thank you, sir.
Naveen sir, you can unmute. Gauri, you can share the presentation and start presentation.
Good evening, everyone. I'm here today presenting the case of baby Ritika, who was born on 3rd of May 2023. Time of birth 8:33 a.m.
Gauri, just a minute. Gauri, just a minute.
34 hours of life. Date of examination on 10th of May 2023, and gestational age of baby was 38 weeks 4 days. Her presenting complaints were yellowish discoloration of skin and eyes noticed since 4th of May morning at 30 hours of life. History of presenting complaints. She was a term 38 weeks 4 days, LGA 3.45 kilogram in her delivery. Her mother's blood glutation of eyes and skin on postnatal day 2. Hence, serum bilirubin was checked, which was 18 milligram per deciliter at 32 hours of life, which was informed to be very high to the mother. Hence, they were referred to higher center for further management. They were also informed that Baby's blood group was B positive. Baby was hence admitted to NICU ICH Kottayam. Blood investigations were done, which showed high total serum bilirubin of 21 milligram per deciliter at 34 hours of life, for which she was admitted and was started on intensive phototherapy. Mother was also informed that the bilirubin values were very high, and if the values were not getting better, exchange transfusion have to be done. Baby was given express breast milk via NG2. Serum bilirubin values were monitored every 6th hourly, and the values were decreasing but at a slow pace. From postnatal day 4, intensive phototherapy was changed to double surface phototherapy, and on postnatal day 6, as her hemoglobin values were falling and bilirubin values were remaining high, she was given immunoglobulin. Repeat values on postnatal day 7 were normal. Hence, baby was taken out of phototherapy unit and was given mother's milk. Coming to antenatal, natal, postnatal history. Baby was born to 26-year-old mother and 30-year-old father. She was the second child of non-consanguineous marriage. Mother's blood group was O positive. First child was 3.5 years old, female child, O positive blood group, and there was no history of neonatal jaundice for that child, and she was normally thriving. First, second, and third trimesters were uneventful for mother. Full-term normal vaginal delivery at 38 weeks, 4 days. She was a female baby, birth weight of 3.45 kilogram, and she cried soon after birth. She was initiated on breastfeeding within half an hour of life, and she passed urine and meconium on the same day of birth. She was being fed too early for 15 minutes, night feeds 2 to 3 hourly, was feeding adequately between sleep, was sleeping adequately, feeding adequately, was passing urine 3 to 4 times on the first day, and let-down reflex was present for mother. BCG, OPV, and hepatitis B were taken at birth. There was no family history of blood transfusion, jaundice, abdominal surgeries, or chronic drug intake in the family. On examination, baby was alert, active, moving all 4 limbs. There was mild pallor. Sclera of the baby was ectric. There was no cyanosis. Heart rate was 140 per minute. Respiratory rate 42 per minute. Saturation was 98% in room air. Temperature was 90 degree Fahrenheit. And in anthropometry, her weight was 3.45 kg at 95th centile. She was large for gestation age. Length and head circumference were corresponding her gestation age. And on head to foot examination, there was icterus up to arms and leg, that is chromosome 4. And there was sclera was also icteric. There was no cephal hematoma. There was no macrocephaly or microcephaly. Other head to foot examinations were within normal limits. And on examining systems, GIT, there was no abdominal distension, no hepatosplenomegaly, and nervous system examination was also normal. Cry tone activity were normal, and modified Bind score was 0 for the child. Respiratory system and cardiovascular system were also within normal limits. To summarize, my patient is a term 38 weeks 4 day LGA girl baby, antenatally uneven, born via normal vaginal delivery, presented with yellowish discoloration of eyes and skin on postnatal day 2, admitted in view of neonatal hyperbilirubinemia, OB incompatibility. There was no family history of jaundice or anemia. System examinations were within normal limit. Baby was treated with intensive phototherapy and IVIG. Currently, baby is on mother's side on exclusive breastfeeding, baby feeding well and gaining weight. And my diagnosis is term 38 weeks 4 days LGA female baby NNHB OB incompatibility. These were the initial investigations of the baby at 34 hours of life. Her hemoglobin was 14.4 and total serum bilirubin was 21.8. Baby blood group was B positive, DCT was negative, and reticulocyte count was 7.8%. And her peripheral smear showed normocytic normochromic with polychromasia and occasional spherocytes. This was the initial charting of her total serum bilirubin, which was 21 at 34 hours of life, which is much above the exchange transfusion levels. This is a table showing her further bilirubin levels. And it shows that we gave IVIG on postnatal day 6. Till then, even though her bilirubin levels were decreasing, it was remaining just above phototherapy level. And on postnatal day 7, it decreased to 13.6, which was below the phototherapy range. Thank you.
Thank you, Gauri. Are you able to hear me, Gauri?
Yes, sir. I'm able to hear.
Good. Very nice presentation, Gauri. This is a common.
Naveen sir, please unmute.
Yeah. Thank you, Suresh. So jaundice is a common problem, but this kind of jaundice, which can be damaging, is not common. And if we miss this as a practicing pediatrician or a neonatologist, a baby may lose his life forever. Gauri, have you ever seen a website called PICK, Parents of Infants and Children with Kernicterus? Anybody has gone to this website? I think you should all note it down today, because if you spend 40 to 50 seconds and see the opening of this website, never in life will you miss this Kernicterus. So in this website, which is a group of parents whose children have suffered Kernicterus and disabled for life. Gauri, can you tell us what would be the chronic neurodisability of children who get Kernicterus as a newborn?
Sir, in Kernicterus, there will be chorioathetoid cerebral palsy.
Very good.
Sensory neuron hair nodes.
Excellent.
Dental enamel aplasia.
Very good.
There can be seizures.
Yes. Good. I think you covered most of the important points. But in this, if you see a child, when you go to this website, you will see a child who is having this kind of cerebral palsy. These children have very, very bad truncal tone issues. They can't sit. They don't have proximal muscle control. They can't control their hand. They can't do anything meaningful. They can't swallow easily. They'll be drooling. In short, they are a total mess. And all these parents only state one thing: my baby was born normal. Imagine that a family is holding a child for rest of his life who will be probably deaf, who will be not able to sit ever properly, who will have drooling of saliva, who will be very, very disabled, except that he is intelligent and knows that he is disabled. So such a child could have been prevented by only a few simple things. So with this in mind, that our purpose of discussing this case is to make sure not a single child gets Kernicterus ever. Can you tell me what is intense phototherapy, Gauri? Because everyone in this group, when we face this situation, the first and the most important action we can take is give intense phototherapy. What is intense phototherapy?
Sir, in intense phototherapy, the source of phototherapy light, usually blue LED light, which covers a wavelength between 460 to 490 nanometer, ideally 470 nanometer, which is the absorption spectrum for bilirubin, and at an irradiance of 30 microwatt per meter square per nanometer. And the lights are kept as close as the baby, and there are minimal interruptions.
Perfect, Gauri. And I urge you, Gauri, since you are the case presenter, that at least when we become clinicians, we shouldn't forget these points. I have to confess, in my unit, even now when I go for rounds, I will find the phototherapy unit high up there. I will find the baby in the mother's hand because the baby was crying. Or blue light phototherapy might not have been given in another center before referral. So you are right that intense phototherapy is the right blue. And the LED phototherapies that we have some advantages over the compact fluorescent lamp phototherapy, because there are a lot of teachers and a lot of heads of departments. I would urge them to try and buy for the unit LED phototherapies, but Gauri will tell you why it is better.
Sir, yeah, in spite of providing a better light spectrum, it is also cost effective, and also there is minimal risk of hyperthermia.
Very good. So you're right that the narrowness of the blue range is very, very, very sharp with LED. So all the 30 microwatts is in the useful blue. In the compact fluorescent lamp, it is little bit spread out. So if you have 30 microwatts through compact fluorescent lamp, in the best range, it may be 20, 10, 10 maybe on either side. And if you're using a white lamp, it may be 5 in blue, 5 in green, 5 in some other color. So even if you're using 30 of a white light, the useful part is very small. If you're using a CFL lamp, the useful lamp blue is much better. In LED, it's perfectly narrow, useful color range that you're using. That is first advantage. The second advantage is in a compact fluorescent lamp that is tube light type of phototherapy, after 5,000 hours or 6 months, what was initially product of 10 microwatts will drop to half. Whereas in LED phototherapy, even after 50,000 hours, it will keep producing the same intensity phototherapy. So even if you're buying it for twice the cost, it will last you longer, and its power consumption is only 1/4 of the standard phototherapy. And rightly you said, it can be brought very close to the baby. Most of our nursing textbook and old pediatric textbooks may still say 45 centimeters, but now it is maybe less than 10 centimeters. We know about blanket. What is this blanket phototherapy? Billy blanket. I know we have not seen it, but can you imagine what it will be like?
It's an LED blanket by which we can wrap the baby.
That's the point. I'll come back. It's not LED, it's fiber optic, but we'll come back. The point is that it's touching the baby. It is so close that it is touching the baby. So it might appear I'm going very slow, but this is very, very important practice points. That if you're giving intense phototherapy, it has to be minimum of 30 microwatts in the right blue, as close to baby as possible. And within 6 hours, you must demonstrate that there is a 2 milligram drop in bilirubin levels. These are of medico-legal importance also. Sometimes by habit, we will do it only after 12 hours. And if this baby gets damaged, we will not be able to save ourselves. So if you're sitting on very, very high bilirubins, like in this baby on first day, 18 to 20 values, the next check is happening in 4 to 6 hours, not after 8 to 12 hours. In this baby, what is the possible cause of jaundice in this baby?
Sir, hemolytic anemia due to OB incompatibility.
You're right. Although there are some atypical findings in this baby. Even though the bilirubin was early and so high to rise, the drop in hemoglobin was not so sharp on the first 2 days. Also, often when we see babies with RH or ABO, they behave very similarly sometimes. The reti count may be to the count of something like sometimes 20, 30. And that is why it had a different name. What is a different name in the olden days? Erythroblastosis. What is the meaning of erythroblastosis? Erythro is red cells, blasts. So they were all having immature red cells, that is nucleated red cells or reticulocytes. And there were so many in number that initially people thought it was leukemia. That much blasts were there in the blood. 30%, 40%, 50% was blast. So generally when you have isoimmune hemolytic anemia, the reti count will not be just above 6, up to 6 may be quite okay on the first and few days. You may have values going up to 30%, 40%. And indications for doing exchange included not only high bilirubin, it included low hemoglobin on day 1, less than 10. Which means many of these babies would have a value which is very, very low. for the benefit of students, whatever guidelines we are reading from one textbook, maybe a Cloharty or a Nelson, is only one guideline. There are more than 15 guidelines for exchange transfusion in the world. Different countries have different guidelines. And they include features like how fast the bilirubin is rising, or it is not getting controlled by phototherapy, how fast the hemoglobin is dropping, how much is the baby's weight and gestation, how is the baby's sensorium. All these are there, and some of them have albumin ratios also. So what is the meaning of this bilirubin albumin ratio, Gauri?
So the bilirubin albumin ratio more than 3.5 indicates a high risk of kernicterus. It means that albumin is not sufficient for carrying bilirubin, and there is a high level of unconjugated bilirubin, which is likely to permeate blood-brain barrier and cause neurotoxicity.
Brilliant. So although this is described very often, most of us are not using it in practice. Now, we talked about giving intense phototherapy. Are there any challenges in delivering intense phototherapy, and what are the side effects you may get on the baby?
So side effects of phototherapy include most common is transient loose stools due to the photocatabolites producing irritation in the GIT. There can be a low risk of hypothermia, even though it is not as much as other lights. There can be hypocalcemia, thrombocytopenia in some cases, flea bite rashes on the baby.
Yeah, although textbook describe all these side effects, these are probably not of immediate concern while we are managing these babies. Immediate concerns would include disturbances in feeding. Like you said, we gave tube feeding to this baby.
Yes.
Many of my colleagues also want to do that. They want to give tube feeding, or they want to shift the baby to ICU so that they can ensure continuous phototherapy. And sometimes they tell the mother that till the bilirubin values are not lesser, do not even breastfeed the baby. They will give Palada feeding, bottle feeding while you're continuing to get phototherapy. The intentions are good because more the phototherapy or continuous phototherapy without interruption, you may save the baby. But this is a personal viewpoint. I am very uncomfortable in stopping breastfeeding. 1 or half an hour of breastfeeding will not disturb baby's bilirubin, because there are enough studies to show that even intermittent phototherapy continues to go on acting for some time. But of course, this is not something I'm going to discuss at PG level. The point is that babies must be continued to feed. What is the benefit of feeding these babies, Gauri, when they're in jaundice?
By feeding, we can decrease enterohepatic circulation of bilirubin.
Good. So feeding must never stop. Yeah, you're right. Go on. Yes, Gauri.
Such that the bacteria in breast milk can inhibit beta-glucuronidase excess in neonatal gut.
Right.
And also it can increase the gut motility so that meconium containing bilirubin will be removed.
Right. Now, how long would it take to arrange blood for exchange transfusion in most units?
So here it takes about 3 to 4 hours.
So which means that when you have a situation like this, you may have to keep blood ready for exchange transfusion. What are the qualities of blood which is used for exchange transfusion?
So we usually arrange 160 to 180 ml per kg of blood. In case of ABO incompatibility, we arrange an RH matched on O group blood, which is triple washed, leukocyte reduced. And as per current guidelines, a hematocrit of 40% is recommended now.
So I'm not sure about the 40% hematocrit, so I won't be able to discuss that. But I am just going to ask that we are talking about blood that should be how old for exchange transfusion?
So within 3 days.
Yeah, British guidelines say 5, but the point is that this is a massive transfusion. We are replacing the whole large volume of blood, and therefore some of the problems that happen with stored blood become significant. What are they?
Hyperkalemia, acidosis.
Yes.
The citrate can produce hypocalcemia,
Perfect.
hypothermia.
You're right. The first two are the greatest importances of stored blood. So if you are going to use blood for exchange transfusion, probably exchange and ECMO are the only two indications where today you can ask blood bank to give you fresh blood. Fresh means less than 3 to 5 days donation. In all other situations, blood bank will give you only blood which has been stored and not give you fresh blood. What are the 5 infections which are standard for screening blood banking in India?
HIV, HBCG, HCV, cytomegalovirus.
Think again, be calm. 5, CMV is not there. CMV is added if preterms are in concern. We are not finding it easy to do it in India still, to have CMV testing for all newborn blood, but it should be the case for all VLBW and exchange transfusion, you're right. But that's not a routine. Routine are 5. You said hepatitis B, C, syphilis, malaria, and HIV. No? All right. So all these 5 should be screened, but if it is a baby who is having massive transfusion, we are probably happy if you have CMV negative blood, and CMV negative donors are very few. So you can do something called leukofiltration at donation. If you leukofilter later, you may still have CMV in the blood. Also, irradiation is done for what purpose? You can irradiate the blood like chemotherapy. You can show radiation and kill somebody in the RBC, in the blood cells. What will die? The active leukocytes will die. They are the ones who multiply very fast. No? So whoever multiply very fast like cancer cell, they will die. So leukocyte will die. If you are transfusing live leukocytes, they can attack the recipient. That is why it is called graft or donor versus host, or graft versus host. You can get a fatal reaction called graft versus host disease when you are transfusing large amount, especially to very premature babies. Right. Now coming back to this baby, in this baby, there is a condition called late anemia. Again, for practice point, what is late anemia in the setting of ABO and RH? When does it present? When should I screen? What may I have to do to treat it? Okay, I'll help you with that. No problem. We said that this is isoimmunization, no? So antibodies from mother will remain in baby circulation for how long time? Maybe 3 months to 9 months. If mother has sent anti-A or anti-B, or if it was RH setting anti-RH antibodies, we know all the passive protection from mother IgG goes for 3 to 9 months in the baby circulation. And the RBC lifespan is reduced, and the RBC will go on sharply falling. So instead of falling like normal babies from 8 grams to 9 grams, by the end of 3 to 4 weeks, instead of 4 to 6 weeks, by the end of 3 to 4 weeks, it may drop to 5.5, 6 grams. Therefore, babies who are treated on day 1 jaundice with ABO or RH as a possibility should have an examination at 3 weeks of life for looking for late anemia. They may require a pack cell transfusion. You have to educate the parents about this. Otherwise, they will think you have complicated the condition. Now, one last point before I ask the other teachers to contribute, and I'll come back again. What is the possible role of IVIG? How does it work?
So IVAG can in fact help in decrease the TAPA exchange of exchange transfusion. In this baby, initially, though the bilirubin values fell, it was still remaining above phototherapy range, and it was increasing day by day. IVAG can decrease the chance of exchange transfusion.
How, Gauri? How does it work?
It can block the FC receptors in isoimmune hemolysis. Hemolysis occurs by FC receptor mediated RBC lysis. When IVAG blocks FC receptors,
Yeah, you're right. So if you think of antibodies, that is anti-A or anti-B antibodies, they come and attach to the RBC. If they die intravascular straight away, that is called as intravascular hemolysis. But in most of the situations, these antibodies attach to the RBC, and then these RBCs become sick. They are going to be picked up by your reticuloendothelial system, liver, spleen, and then they are killed inside that jail. We think that this IVIG blocks the gates of the jail and don't allow this RBC antibody complex to go into the jail and die there. So their lifespan is less than normal RBC, but much better than RBC who go into the reticuloendothelial system. So if you give immunoglobulin, it will prevent this antigen antibody complex RBCs from being taken up into the RAS and being killed there. And therefore, most of the papers who have considered IVIG as a therapy have tried to give it as early as possible, so that you will block the system before it starts taking up the antigen antibody complex. This is a fetal thing, it's happening in the fetus itself. Second thing is that this is something we have studied ourselves, that when you give this antibody complexes blockade, sometimes the bilirubin remains at 18, 19 for several days. And it makes it more hell. And we do not even know whether high bilirubin lasting for several days has effects on the baby's development. Therefore, what we tried as an innovation 15 years back is that we did first an exchange transfusion, removed large part of the RBC antibody complexes, bilirubin levels, then gave immunoglobulin so that second and third exchange may not be required. Most of the places in the world which still think of IVIG as a treatment are probably using it only in those units where exchange transfusion cannot be performed, because either a good blood bank is not there or expertise in doing exchange is not there. So in centers where you can do an exchange transfusion, if you're sitting on a value which is very close to exchange, it may be a good idea to do an exchange and then give immunoglobulin. Otherwise, you will give immunoglobulin, next day you will be doing exchange. Okay. And immunoglobulin is a blood product, true or false? Yeah, it's a pooled antibody taken from 25 people. So how many of you would want to give to your family member a blood product which is taken from 25 donors? Some of them may be professional donors. You understood? So we have to explain to the families that you are going to get a blood product. You have to get consent. You are going to get a blood product. And very rare complication of IVIG is there where you can get NEC-like picture also. I'm not sure whether I lost my attention span. Did you mention about splenomegaly, Gauri?
No, sir, there was no splenomegaly.
All right. Yeah, I'm not sure whether you said there was, you should have said clearly that there is no splenomegaly, because many of these babies who have long-standing immune reaction going on inside, they may have a splenomegaly also. So look for splenomegaly. So I'll come back to 2 or 3 questions after I ask other teachers to contribute. One question I'll be asking you later when we come back is, what is the role of brainstem evoked response audiometry BERA in this baby? What is the role of MRI? And how long and how should I follow up this baby if I discharge them? What is the advice for next pregnancy? Only 4 more questions from my side. Over to Suresh sir, and many other teachers are there in the hall, so they will ask you some questions.
Thank you, Naveen sir. Thank you, Naveen sir. Okay, we have Virendra sir is here. Purushothaman sir is here. Sir, you can contribute.
Excellent discussion, Dr. Naveen and Gauri. About the case, because I am not a neonatologist, I'm out of touch with the neonatology part. So anyway, in the presentation, as Dr. Naveen rightly pointed out, one most important point which you missed was the mention of the spleen in that situation. And another thing in the general examination, the posterior fontanel and anterior fontanel, because hypothyroidism, of course, is one very important thing in the general examination. And in the history, I heard you mention the patient was fed with express breastfeed. It was a term baby, 3.25 kg born without any problem. What was the reason why the baby was fed like that?
On 2 feet. That too on 2 feet.
On 2 feet, sir. That indirectly says that the baby, that's not expected from this baby. So what was the reason for that?
Our intention was to give intense phototherapy, not to interrupt from the light.
Is that a routine practice? We are keeping the patient, especially in the LED light and all. Is that the water requirement that much high to give 2 feet?
No, sir. It was because the bilirubin values were so high. It was much above exchange transfusion levels.
I'm sure that, no doubt about that. Frequent feed itself will be enough, I think, because my knowledge of a term baby feeding well, if it is active, there's no need for extra thing. And an important thing, always mention about the neonatal reflex when you're present. Clinical examination should be complete, just like above. In that situation, that's very important. Thank you, Naveen.
Virendra sir, are you there? Virendra sir? Naveen sir, I want to ask you a point regarding that. So when you think tell about the intensity phototherapy.
Yes, Suresh.
And term baby is on breastfeed. There is any need to give IV fluids when the baby is under phototherapy?
Very important question, Suresh ji. While we were residents in PGI, during summer, our exchange transfusion rates used to go twice. One DM trainee used to be posted only for doing exchange transfusions. So there was a hypothesis that in summer dehydration happens and the jaundice becomes worse. So there was a randomized control trial done, very well designed randomized control trial by Praveen Kumar sir and his PG after I passed out from there. And that was giving IV fluids to one group and no IV fluids and standard care to another group. They could not demonstrate any difference in the drop of bilirubin rates. So although maybe if a baby is overtly dehydrated, like baby is having a weight loss which is very high, a baby is having hypernatremia more than 150, maybe you can think of free water like 10% dextrose to be given. But if the baby is having ability to feed, I will go with Purushothaman sir, that just feed him a lot. And maybe that is more physiological than IV fluids. In a baby who is not having overt dehydration, the risk of infections and disturbing physiology is more with IV fluids.
So you mean to say that there is no necessary need to give IV fluids unless the baby is dehydrated?
Unless there is clinical and lab evidence of dehydration, weight loss, as well as.
Thank you.
Yeah. I had Sushma madam, my teacher and my examiner. Madam, any some comments, ma'am?
Sushma bhai, madam.
Madam, unmute here, madam.
Good evening, madam.
Unmute here,
please unmute.
Madam is muted.
Did she say anything
Okay, madam.
about the
I will do
Moro
that.
reflex? Can't hear.
Moral reflex was complete, ma'am.
Complete.
Madam, you want to add anything more?
No.
Darling, ma'am.
Nothing to add. Nothing to add.
Chanava, sir. Okay, then I'll just go ahead quickly because I think I have promised Gauri will finish in 40 minutes. And another 4 quick questions, which we said. What is the role of brainstem evoked response audiometry or BERA, which we do around 3 to 4 months of age in these babies? Quick answers.
Sir, and bilirubin hyperbilirubinemia, especially in extreme zone, it can cause sensory neural hearing loss.
So can a baby who has sensory neural loss pass OE?
Yes, OA can be passed, but BERA can be show abnormal.
So baby's nerves are having a problem. OE only tests till your hair cells.
Yes.
So please remember, this is not for only the discussion inside this Zoom meeting. It is for practice. Babies who are premature, babies who have hypoglycemia, seizure, asphyxia, very high jaundice, they must be advised to do BERA. If you don't have BERA in your center, find out where it is, but please advise them around 4 months. 3 to 4 months is an advice because if you find hearing impairment, then you will be able to correct it before the child starts developing language development at 6 months of age. The second question is, if I do MRI, what will I find?
Sir, in MRI acute phase, in T1 there will be hyperincident signals in globus pallidus and also in subthalamic nucleus. In chronic cases, there will be T2 hyperintensity in cerebellum, dentate nucleus.
Yeah. So very important that all these babies who have had encephalopathy, that means they were lethargic, and that is what the most important point Purushothaman sir told you. The minute you put a tube feed, you will get into medico-legal problems tomorrow that they may think that baby was lethargic enough not to take oral feeding. So if you have a baby who has encephalopathy, you do MRI to make sure that there is not another disease in the brain which is responsible for encephalopathy. The next question was there is, what will be the follow-up plan for this baby? Till how long and what follow-up should you do? Many of the teachers asked you, did you do Moro reflex? So at discharge, you can do something called Hammersmith newborn, but I won't go to do that. At 4 months, if I do this testing, think of my teacher MKC sir. What are the 4 milestones you will look? At 2 months, what should baby do? Term baby at 2 months, what milestone you should get?
Mother can't going.
Social smile.
Social smile.
4 months?
Neck holding.
Head control. 8 months?
We should look for sit without support.
And 12 months?
Stands without support.
So at least this much we all pediatricians should do to a NICU baby. At 2 months, if smile is not there, don't say, let us see. It is a very rigid milestone. 6 to 8 weeks, no smile means no smile. It is a problem. Immediately start investigating. 4 months, head control. CDC grading is there, but which means basically stable head. 8 months, the child should not only sit, he will sit without a rounded back. He'll sit straight. He can turn around and play like that. He can use his hands. He won't fall down. That is a mature sit. Even if he can't stand independently, he can push a chair around anywhere and go. So these 4 milestones plus make sure child can hear. Language development is there. Now, some questions were there in the chat box. I'll just quickly answer them and then leave it to the teachers before we close the session. Immunization. Live immunizations may have to be deferred for a variable period. Today, the next live immunization, which will come, Gauri, after this in this baby? What will be the first live immunization that will come on this baby? Live vaccines.
9 months.
9 months. 9
Yeah.
months.
Say today you're giving Pentavac, it contains IPV also. So polio will get covered. The 9 months will, by that time, most of it is safe. Although immunoglobulin effect can last till 9 months. So there will be no altered immunization plan broadly. How long should you test bilirubin after IVIG was one question. I think there is no change. If you are sitting on a situation where you think IVIG was required, it is severe hyperbilirubinemia, 4 to 6 hours bilirubin checking. And then there was a question, exchange transfusion in preterms. It is very difficult decision making because in preterm babies, one side you are having a preterm brain which can get easily damaged. Other side, a preterm baby who can get harmed by exchange transfusion. It is not a therapy without side effects. So always we try intense phototherapy. But if there is even one early sign of a baby having encephalopathy, then rotavirus is a question asked. We don't withhold. We are giving rotavirus vaccine. Corey, you want to ask some questions to the teachers? You should get chance to take revenge, no?
Naveen sir, I have a few questions. Can
Please,
I
sir.
ask you?
Please, sir.
Suresh. One is that, sir, is your exchange transfusion plan is dependent on the postnatal age of the baby? For example, the baby is coming to you with a bilirubin value of around 25, like that time maybe 3 kg. At 25 value, maybe in the exchange shown by your charts. And only because baby is active, feeding well, and is on now past day 5 or 6, does it mean that you have to defer the exchange transfusion, or still you go by the cutoff values for that day?
Very important question, sir, because over the time we have been taught that this blood-brain barrier matures, and as you get older in life, the chance of kernicterus decreases, and that is why you can see all the charts go up like that, besides liver maturing and clearance happening. But the bottom line is that I told you there are more than 15 guidelines for doing exchange transfusion, which are national guidelines of 15 countries. And they have used different criteria. But the common thread seems to be development of encephalopathy. So I think the only one message if I have for closing this session before the other questions come, my last suggestion to Gauri and friends would be stop writing baby has jaundice. It has no meaning. Baby has jaundice and encephalopathy, or jaundice and no encephalopathy. So if baby is saying jaundice and sucking well at breast, crying and asking for feeds, making normal movements, nobody can take you to court tomorrow. No baby will die of kernicterus tomorrow. No baby will get damaged. But if the baby is having lethargy, even if the cause is sepsis, asphyxia, hypoglycemia, any other cause, if he has lethargy, he will undergo exchange transfusion right away. The second point which Suresh ji said, even if they come on first day and fifth day, we always try intense phototherapy even with values like 28, because anyway you need 4 hours to arrange blood. But we know that if it is on the 6th or 7th day, most of them are readmission jaundice. This is where the poor feeding is a major contributor. But in the early one, it is never because of poor excretion. Excretion is 0 on a day 1 baby for all. It is because of increase. So it is mathematics, no? Production minus excretion. In all babies on first 3 days, excretion is 0 anyway. So if bilirubin is rising, it is high production. So if you see in the first 2-3 days, that is why it is pathological, because it is clearly saying it is increased production. Now, one more point, which is nothing to do with jaundice, for Gauri and young PGs, on the first 1 day and second day, a sign of good lactation is not that babies sleep well after feeding. It doesn't happen because babies are not getting milk, they're getting only colostrum. Because you presented that, people make mistake. In fact, this time in the second edition of Cloharty, which will come in 4 months, we have written a large chapter paragraph to say students should not make a mistake in saying on first day that baby took feed, passed motion, passed urine, and slept well for 3 days, so mother has enough milk. No mother has enough milk on first day. It is only colostrum. On the first day, only sign of knowing the feeding is going on well is latching. The baby latches well at breast. You are not getting milk. This example of getting milk, passing motion, passing urine, and sleeping well is after 1 week of life. That is when it becomes a sign of enough feeding. Does cord bilirubin help? Yes, cord bilirubin has been used for prediction. one of the study from AIM showed that if you have a cord bilirubin more than 2.5, then the need for phototherapy was much higher. Chance of bilirubin toxicity after 2 weeks is not probably common in the situations that we see, but there are genetic disorders of bilirubin metabolism. And I will only confess that I have not seen even 1 in 20 years of practice. So don't think of those rare things first. But if your bilirubin is going on 30, 40, 50 like that, then they can get kernicterus at any point of time. So if you are having a bilirubin on 15th day, which is going 30, 35, you may still do phototherapy, exchange transfusion, whatever. Somebody asked about peripheral route for exchange transfusion, very challenging. You will find it very difficult to do. Can phototherapy be given late? It is a safe therapy. If it is indicated, you can give it. Although you must look for direct bilirubin in any baby who has jaundice, which is still troubling you after 2 weeks. That's all I have to say, Sureshji.
So nothing more to add. Nothing more to add. Anybody wants to ask any question, you can ask directly, sir. Or you can put in the chat box. If any more things has to be answered, please put in the chat box.
Yeah, Dr. Sajan is done.
Sir, a question on
Dr. Sajan, why don't you please tell us also? Dr. Sajan, I have no experience. Please tell us.
Dr. Sajan, sir, please.
Hello, can you hear me?
Yeah, please.
Yes, sir. Yes, sir.
I have a few points to add. One is that we have done a study of cord bilirubin in ABO incompatibility back in 2002. And it has clearly proved that it does help even in ABO incompatibility in preventing exchange transfusion. So we are supposed to do cord bilirubin even in ABO incompatibility babies for all babies. That's what we are doing in our unit currently. We don't do any exchange transfusion for ABO incompatibility because of this principle. If the cord bilirubin is more than 3, definitely we will be careful. We may start phototherapy, or we will repeat the bilirubin after 4 to 6 hours. If the bilirubin is rising, definitely we will start phototherapy. And Crigler-Najjar is a condition which we have where we have to do exchange transfusion even after 2 weeks of age. And third point is that I have a patient had complaint against us because this baby is a preterm baby. We have done bilirubin up to around 14 days. It was normal. On day 20, bilirubin was around 20. It was just above exchange transfusion level, 1 milligram above exchange transfusion. And we have given phototherapy and baby has improved. That bilirubin has come down to around 8. But this baby later developed cerebral palsy. Even MRI was not showing anything suggestive of bilirubin toxicity. Still, the parent complained that since you have not done exchange transfusion on day 20, our baby developed cerebral palsy. So these types of medico-legal problems are there in managing bilirubin toxicity, especially. That's why we are saying that we should be very careful. If the bilirubin is more than 5 milligram above the line of exchange transfusion, if the second value after 4 hours, if it is still above, we have to do exchange transfusion. Otherwise, later they may come up with medico-legal problems. And giving IV immunoglobulin after 24 hours, we don't do. Because once it is, the antibody is attached to the RBC, there is no use in giving IV immunoglobulin. So the problem is that if the baby goes well, that's fine. But if the baby develops any cerebral palsy, we are in trouble. Thank you.
Thank you, Dr. Sajan.
Thank you, Sajan, sir. Thank you, Sajan, sir. So, Naveen sir, again, Sajan sir makes to get a clarification, I am asking it again. So if you have a baby who is coming in the exchange level, you plan with arrangement of the blood exchange transfusion and moving with that. Meanwhile, you are starting with intensive phototherapy. So the next value after 4 hours, it comes below the exchange level, should you go?
Dr. Suresh, I got your question, even though I lost your voice in between. Is that while you are arranging for exchange transfusion and the values start falling, if the value is still under exchange level, over exchange level, would you do an exchange?
So the first value was above the exchange level. So we planned with the exchange transfusion, but after 4 hours, which is dropping, to say that it has moved below the exchange transfusion limits. So whether to move with the exchange transfusion after, so we are not sure what will happen in the next 4 hours time. Whether we'll be having.
Yeah, my principles are very easy. Is that we have 2 types of jaundice. One is called early jaundice and late jaundice.
We are going to get or not, we are not.
Early jaundice is what presents on first and second day. It is always happening due to increased production. Either it's ABO, RH, G6PD, pyruvate kinase deficiency, something like that. And in such setting, if the bilirubin is falling a little bit, but still remaining over exchange, I would do exchange transfusion. Because this bilirubin is high and will continue to be production. But if it is late, what is called as readmission jaundice, they go home and come back and have a value of 26, 27, then probably will not do exchange transfusion. We will try to give aggressive phototherapy for some more time. But at all point of time, we would continue to record the encephalopathy scores, and we would keep informing the family that we are consciously taking a decision not to exchange transfusion, and we are ready with exchange otherwise.
Naveen.
Thank you, sir.
Naveen.
Yes, sir.
Not in this context. My doubt is there is a role for the neonatologists in the IAP committee on immunization, especially in the preterm, low birth weight baby and sick baby immunization. The preterm low birth weight baby, definitely there is an agreement that the chronological age should be followed rather than the present doubt of we are doubting, and many of the cases we are delaying the vaccination just because of the concept the prematurity. Actually, they need the vaccination to be given early, and the safety part, the efficacy part are all acceptable. And regarding the vaccination, when the baby is inside the NICU, if they are low birth weight or prematurity, but they're kept there only for that, they are not that sick, we should be giving the vaccination inside the NICU also. Another situation is the situation like this. For multiple reasons, maybe you are giving some of the drugs which can have a long-term immunosuppression. It's not a real immunosuppression. The vaccine efficacy may be a little low for a longer duration. IV gamma you are giving for just 1 dose, maybe it has got a bearing on the antibody conversion for the vaccination of the primary and even up to more than 6 months. So in the committee, should there be an extra dose? The initial dose may be considered 0 dose and there is an extra dose needed, either that way for extra number, or maybe the need for the antibody level estimation following the primary doses. So there is a role for the neonatologist's words in the IAP committee on immunization.
Thank you, sir. I got your question clearly. When it comes to preterm babies, however preterm the baby may be, chronological vaccination should happen. So we have been practicing for last 10 years that 24 weeks baby, when he reaches 8 weeks, he would be 32 weaker. He may be just 1.2 kilo. We are giving full vaccination, DPT, all those things. So recently we published this paper where we try to see that what are the risk of getting apnea and events after getting this vaccination when they are 32 or 33 weeks now. They started as 24 or 25 weekers and 8 weeks of age now. So these babies we vaccinate. If they are already bronchopulmonary dysplasia babies who are oxygen dependent, they can have more events. But all other babies had only transient events and did not require restart of caffeine, CPAP, HFNC or ventilation. So you can go ahead and give. But they should not be given out of monitoring. They should be under monitoring. Regarding this immunoglobulin and giving vaccination, there may be a possibility that some of the effect of vaccination may be attenuated, but still the vaccines go on per schedule. Currently, world over, there is no recommendation on measuring the immunoglobulin levels in clinical setting after giving the vaccine. In experimental research settings, people have measured the antibody levels of the vaccines in premature babies and found it to be lesser than term babies, but more than the threshold for giving protection. For hepatitis B, there were some guidelines regarding an added dose, but recently I don't see such a guideline. We continue to give the standard doses. This is our practice.
Sushma madam, anything more to add? Sushma madam.
No, I am studying.
Surya, are you there? Surya being the mentor for the case today. Surya is now in charge of our neonatology unit at ICC now. Surya, are you there?
സൂര്യ മെന്റർ എന്നുള്ള നിലയിൽ സപ്പോർട്ട് ചെയ്തതിന് നമ്മൾ ഒരു വാക്കും പറഞ്ഞില്ല. രണ്ടാമത്തെ കാര്യം, എനിക്ക് സൂര്യനെ അറിയില്ല. അപ്പൊ സൂര്യ മുഖം കാണിച്ചില്ലാത്തതുകൊണ്ടൊന്ന് മുഖം കാണിക്കുകയും ഒന്ന് പരിചയപ്പെടുത്തുകയും ചെയ്യണം. പുതിയ ആളുകളെ നമ്മൾ അറിയണില്ലല്ലോ.
Surya, are you there?
It's Suresh.
Okay. Video on ചെയ്യാമോ? സൂര്യനെ കണ്ടിട്ടില്ലെന്ന് പറഞ്ഞു. Purushottam sir. Gauri has done reasonably well.
Thank you.
Surya is now in charge of our neonatology unit. Surya, you want to add anything?
There is one question. The thing is that our babies are getting discharged earlier by second day. So most of the babies, what about the follow-up plan for these babies? So
I know the challenges are much higher in a public health setup where the number of babies are at least 20 times the number we see in private sector. But then the responsibility becomes even more greater because many of these babies are not going to come back. Or if they come back, they may not land up in the hands of a senior teacher. They may face a first year PG or a house surgeon in the emergency room. Therefore, we must probably either verbal or written or news or CCTV, some message has to be given that these babies can develop jaundice, which will keep increasing on the first 3-4 days. And that this is a very, very dangerous thing if it does not get controlled. Sunlight may be given for good health, but not enough to prevent jaundice, which is dangerous. And that if you feel the baby is not feeding well, don't wait, it is too late. So even if they can't come back to you, tell them to show a pediatrician near home. This is for young postgraduates. Many of the pediatricians who are practicing out of medical college may be very senior and experienced, so don't look at them as GPs. They will be very useful. They can follow up these babies and help you. So ask them to go and meet a pediatrician if they can't come back to you. But they must all get a visit within 48 hours of discharge.
Sir, what about doing the pre-discharge bilirubin values for all these babies when you are discharging them early?
Yeah, it is very useful. Our own study was done to validate Bhutani Sir's chart in Kerala population by Ashwati. And she found a value of nearly 13 or 13.5 to be the threshold. Most babies who are more than 13 to 13.5 landed up getting bilirubin values which were high, which required phototherapy within few days. And therefore, if you are having a transcutaneous bilirubinometer, it's very accurate till 13. So if you do a value in more than 13, do a lab value, alert the family. If it is less than 13, then maybe you can tell them the risk is low, but still they must follow up because some babies who don't have a high risk in the beginning, either because of poor feeding, cephalotoma, late preterm, they can have a high value later, or even innate genetic reasons.
So you mean to say that in lower values, transcutaneous bilirubinometry is as good as predicting the
less than 13, it is very useful.
Any more questions?
I'll help Suresh by trying to close the session because the Zoom meetings can go on. We love talking to each other. But only 2 points. Okay, one is if you write bilirubin, write
no
encephalopathy or no encephalopathy. Second, give intense phototherapy. You rarely need exchange if you do that. And all of you write down this PICK, Google PICK and write connectors. Otherwise, some other pic will come up. PICK connectors, see the video and you will never miss connectors in your life.
Okay. So
Sergeant sir has asked about G6PD. I think it's an important question. G6PD, last part, one question. In PJ Chandigarh, it was very common. First thing I was taught by my senior when I went to PJ Chandigarh was, unlike in Kerala, jaundice doesn't behave in Chandigarh. So you see a baby's bilirubin in the morning, it will be 12, evening it will be 25. And it can be very embarrassing and you think that you missed it. So G6PD can cause bilirubin to shoot like that. And there are pockets of Kerala which have G6PD deficiency. So depending on where you are, it may be important.
Maybe in the follow-up, the spleen palpation should be done at the time of discharge and maybe in the next follow-up, and maybe a peripheral smear also will do, because when you're diagnosing a case OA or OB incompatibility, and in that stage maybe you cannot completely rule out the other hemolytic anemia. Sometimes it may be possible, like G6PD or spherocytosis and all. Here it's a my MCV was 117, nucleated RBC was there. That's all possibility for OB incompatibility. Still, the peripheral smear follow-up at 3 months and maybe looking for the spleen on the follow-up is needed, because hemolytic anemia some other times may be mistaken.
Thank you, Purushothaman sir. So it's almost reaching 9 o'clock now. We will wind up the session now. Thank you for the wonderful session for the day. And I also like to thank Gauri and Surya for preparing the case and presenting it in a nice way. I also thank the senior faculty members, Sushma Madam, my own teacher, Purushothaman sir, then Sergeant sir for joining the session and adding flavor to the session, more flavor to the session. Okay, with that few words, let me conclude the session. Have a good day. Good night. See you all. Thank you. Naveen sir, I take this opportunity to request you to have another session when you are free, when we have a good case for the next day.
Thank you. I'll enjoy joining you. Thank you so much.
Thank you, sir.
Thank you, sir.
Good night.
Good night.